My heartfelt gratitude to all the chairpersons, Dr. Dhaval Patel, Dr. Nikunj Vithlani, Dr. Hiral Shah, Dr. Rajesh Prajapati and Dr. Sandeep Patel. Everyone, please sit on tables. You can bring your lunch and sit.
Let's bring in the last scientific sessions for the day. I warmly invite all the chairs, Dr. Anil Patel, Dr. Mukesh Goel, Dr. Yogesh Desai and Dr. Siddharth Jain.
Up next, we research in India. Please welcome Dr. Samir Patel, sir, for further discussion.
Good afternoon, all. So, I welcome Dr. Samir Patel, sir, for this interesting lecture. And we all know him. He is a professor, Department of Critical Care, Internal Medicine, Shri Krishna Hospital, Karamsad. And his area of expertise is ultrasound in critical care, NABH, hemodynamic management. Thank you.
Good afternoon. बहुत खराब टाइम में लेक्चर आयुष. Everybody is taking lunch. I know it is a lunch time. We are running little late, but this is important topic. Just one question to audience: how many of you have done CPR? Okay, which guideline you are following? AHA is from? Trump guideline. Okay. So why we are not using our guideline? Sorry, sir. So that is what we are going to discuss. This is our hospital and our team. So cardiac arrest research, that is what we are going to discuss today. So what is the problem? As in my first question, the problem is obvious. We don't know our guideline, or we don't have our guideline. Research done in India till now, we all know research not on cardiac arrest, but any topic, we are always behind. We do everything, we don't document, we don't do any research. That is a fact across all over India. Unique issues for India: registry, formulating guideline protocol and limitations. Okay. So cardiac arrest, major public health crisis, 10% of all death. Indians have little heart issues are little earlier. CAD is a primary cause. This is a well-known fact for all India. We know without any research or documentation. We know this is happening in India. But the surprising or what is disheartening is survival rate is less than 10% in out of hospital cardiac arrest. These are documented. 25% in hospital. But most of the patients are terminally ill in hospital. So this data, survival rate out of hospital is very poor in India. So the data, if you compare our data from the Western data, the outcome and survival rate are much better than us. But why it is so? Why Indians have a poor outcome compared to the Western literature or Western data what we are using? So if we go in the history, this is the International Liaison Committee of Resuscitation, and under which there are different societies from all over the world is working. This is our data in 2011, guidelines for resuscitation in India, that has come up with the association with all ISA, Indian Society of Anesthesiology, everything. And 2011, that was the first data in India that has came up. Officially or in a more scientific way, the CPR education began by ISA and established training center under the IRC, Indian Resuscitation Council, that has started. 2021 officially registered as a IRCF, Indian Resuscitation Council Federation in India. From 2018 to 25, India has shaped many national guidelines and contributed to enhancing global resuscitation practices. So this is how it has evolved in our country in spite of having maximum number of patient or cardiac arrest. Less than around 25-30% number of patients in USA, still they are able to formulate American Heart Association guideline that we are following. Simple reason why we are relying on AHA or ACLS or BLS for training or educational purpose. The simple reason is we don't have enough and genuine research from India. It is not available. Anywhere you go, it is not available. CPR ની વાત આવશે કે તમારા કાર્ડિયાક અરેસ્ટની વાત આવશે, પહેલું મગજમાં શું આવશે? AHA. But we don't know the AHA guideline has been formulated on basis of research on their population, not on Indian. So these are the Indian studies that have been done till now on Indian population. But believe me, these studies doesn't represent the whole India. Suppose this study in Delhi has been done, that is particularly true for that hospital or that area only. It is not a widespread or universally accepted like AHA. So we need our own data. This is the reason why we need, because only 10 or 11% are transported by ambulance by ambulance person. If you compare this data to Western, it is 62 in bystander CPR. If there is so much discrepancy in our data and USA data, how we can implement AHA guideline to our population? That is totally waste of time. It is not applicable. The further reasons I am telling you, Indian population, forget about cardiac arrest, in any research, any disease, any syndromic approach, we are genetically different than the American population. Our genes are not same as the USA people or Western people. Metabolic syndrome, as we are diabetic capital of the world. So our profile, our presentation, our manifestation of disease is different than the Western one. Lifestyle transition, hypertension and obesity. So every way, every disease wise or from all angle, we are not same as the Western public. Even further, if we go the infrastructure, the available facilities, the level of knowledge, like bystander CPR, how many of us or our population knows the CPR? When we are giving a training to the laymen, the calls or the whatever, the BLS, it is said that in Western population, it is compulsory from the school or college level. So by and large, each and every person is at least aware of what is CPR or they know how to do CPR. In bystander, only 1% of Indian population is aware of CPR. Talking about the common public. So you cannot compare the outcome, what AHA is showing, and that is not applicable to our population. Because we are different and we are far behind them in all the ways. So we have to come up with our own resuscitation guideline and our own data. IRC calls BCLS, CCLS. I hope everyone is aware about IRCF and our guideline. This is the compression only life support, basic cardiac life support and cardiac life support, that is ACLS, that is advanced one. So these are the guidelines has been published and we are following it. There are training centers also. But again, as I said, the research has been done in India or in our population is hospital based. We don't have national registry like Americans have. Or AHA guideline has been based on the their own registry. They have fixed guidelines, fixed formulation. Any CPR done anywhere out of hospital or in hospital, they have to fill a form and that should be genuine one. Tick mark nathi apda jevu. Just to write or to complete the formalities or to just complete the paperwork. Apde ત્યાં this is a very common. This is disheartening, but this is true and we have to accept it, everyone. So we don't have any national registry, unlike many developed countries, hampering the ability to track outcome, identify threat, develop evidence-based policies. So every hospital following a different policies every state is following different policies. Because we are lacking a national registry. We don't have it. So this is a high time to develop a national registry and I am glad and I am thankful, I am proud to say that Anuj Bhai has started that registry, that is Arrest Outcome Consortium. It has been started since 2021, I think. We should all clap for it. And in Gujarat, our is one of the hospital that is a part of this registry. One is from Ritesh, Baroda, Surat, Karamsad, Ahmedabad. So it has been started and till now, this paper was published in 2023, more than 2,000 patients data we have. And I know the forms and the details, every minute details are there in the form. And he insists, whatever is done, please document it. So we should have a real ground reality data. Khotu karyu છે તો khotu લખો. At least we have a real data કે what is happening at ground level in India. After 2023, there are lot many hospitals and patient data has been included and I think till now we have more than 5,600 data. Till now we have is going to publish it again. So this, as I mentioned, this form, AOC registry, there are forms, it is online, very easy, and you will get all data. The only request is fill the genuine data. Nothing કર્યું તો write not done. ખાલી નંબર just box fill કરવા માટે કરવાનું છે એવું નથી કરવાનું. Unless we have our own data that is real and genuine, we will not able to form a guideline or modify a guideline. Okay. And requesting everyone to enroll in this registry, your hospital. Whatever data, 5, 10, 15, 20, જે patient થાય, at least enroll. So we will know what is happening all over Gujarat and later on all over the other parts of India also. Challenges, of course, this is not without challenges. Infrastructure system challenges are there. Limited AED availability. AED આપણે હવે ACLS માં બધા ભણીએ BLS માં AED યુઝ કરો પણ how many of new AED available ક્યાં છે આપણી જોડે ઇન્ડિયામાં? કેટલી જગ્યાએ અવેલેબલ છે? Unless we show it to government that this is the real scenario, ખાલી એરપોર્ટ સિવાય અત્યારે કહીએ નથી અને એરપોર્ટ પર હશે તો nobody knows ક્યાં છે. So unless we show ground reality to government or policy maker, things will not change. But we have to show them and we have to do thorough research for them. We should have a solid data for that. And this is one of the platforms to show the government what is reality and what data we have. Underdeveloped EMS system, we all know. Delayed hospital presentation, 85% of patient coming after 6 hours of symptom onset. In contrast to USA, I know that the mean time is 11 minutes. क्या 11 मिनट ने क्या 6 कलाक? How can we compare the outcome of AH or American registry to our? Just it is sad to say workshop માં બધે વાત કરીએ છીએ પણ ground reality is very different. That we have to accept it, and we have to accept it and try to change it. માનીશું જ નહીં તો ચેન્જ નહીં થાય. We have to accept that these are the loopholes, but we have to try to rectify it. અને એક બે માણસથી નથી થવાનું આ. જેમ મનુજભાઈ કહ્યું એમ we have to collect data from Gujarat, later on from the India. We have to show it to policymaker, then only things will change. So concluding my session, India reveals very critical high incidence, but the good thing is, this was another study, that Indians are willing to learn, get trained and more involved in the research. So બધું જ ખરાબ નથી. Efforts કરીશું, so things will change. Okay? Thank you. Not able to come, so I am taking it. Thank you. Anuj bhai, if you want to say a few words.
This is thank you, Samir bhai, for bringing this topic on table. This is the truthful data, and that's why we are going slow in recruiting the hospital. This software is made in 2017, and as in 2025, we have around 11 hospitals across Gujarat and Maharashtra who is enrolling the data. To maintain consistent data enrollment is our real challenge. And I'm very proud to say that now Indian Resuscitation Council Federation has decided, declared Indian Resuscitation Council Federation's registry also made by us in Surat.
Yes.
It is called ICPR registry. It is under trial phase. And after this AOC registry, we have sort of got the contract of making IRCF Indian registry. We have made it in Surat. And we are very proud that it will be launched soon after the trial is over. So it is, yes, we are ready for it, and I'm very proud that yes, this happens in Surat.
Yeah.
And we encourage that all, yes, as Samir bhai said, our data today, also you can see in www.aocregistry.com, you will have a live scoreboard, just like cricket scoreboard. Cricket chalti hoy to live aave na. If you want to give a lecture today on CPR anywhere in Gujarat, you can say that in AOC registry, today we have 5,669 patients. The good survival rate is 8%, OHCA survival rate is 9%, and OHCA survival rate is 4%. IHCA is 9%. This is our data. So tomorrow if you ask that when should I stop CPR in India, our data will give us that when to stop it. Thank you very much.
Thank you.